Hey everyone. I wanted to kind of record a lecture um, on alcohol specifically for our policy class, and it's primarily because I'm an alcohol researcher. So we're going to stray a little bit from policy, but I at least wanted to give you an idea of some of what's sort of going on in the alcohol world, and I'll bring in some of the policies that sort of are relevant, but. Again, since this is sort of my area, um, we can stray a little bit from sort of policy, and talk about some of the broader things that are going on. So we'll start with some statistics, just sort of on alcohol use, and then talk about some of the treatments. And like I said, I'll bring policy into it. So, believe it or not, alcohol is actually the most widely used and abused mood altering substance. So there's 330 or so million Americans, and just about 180 million of them report alcohol use in the past year. It's about 2/3 of the population. Now, not all alcohol use is problematic, and certainly lots of people um, drink alcohol even fairly regularly, and it doesn't constitute a problem. So, one of the things that's kind of interesting about alcohol is that we can't assess problems simply by assessing the quantity and frequency of consumption. Alcohol use disorder is what sort of the DSM-5 label for alcohol use that persists despite the fact that it's causing problems to mental health, or sort of social well-being. The number of people who have AUD in the U.S. it varies pretty wildly. Um, about 10% has a lifetime history of alcohol use disorder, but at any one point, we're probably looking at about 15 million people. That could be a little bit higher, it could be as high as maybe 25 million. But the point of that is that alcohol use disorder is the most common of the substance use disorders. Um, Rates of treatment seeking are really low. They're less than 10%. And certainly not everyone needs treatment. There are people, like we'll talk about here in a few minutes, there are people who can recover on their own, and there are people who engage kind of self-help groups to recover. But there is an unmet need, and I'll show you a slide here in a couple of minutes. The most common pathway towards treatment is a physician referral. So, a person goes to see a doctor for some kind of problem. The doctor notices, asks questions about drinking for whatever reason, because it's clinically indicated, and they make a referral. For treatment. So of the 14 or 15 million who have alcohol use disorder in the past year, there's another 25 or 30 million with sort of problematic use, and that might mean that it's caused problems. There's been an impaired driving offense, that kind of thing. But alcohol use disorder is actually a really significant threat to public health. Alcohol is related to the third leading cause of preventable death in the U.S., and it has been for many years. And it adds, between 250 and 300 billion to healthcare costs annually. Just this absolutely kind of exorbitant amount of money. Believe it or not, alcohol use disorder is a bigger problem than opioids. So you can see that this is alcohol use disorder versus opioid use disorder. I believe that these data were from 2019, but there's about 7 times as many people with an alcohol use disorder. Close to 4 times as many ER visits related to alcohol. 4-ish, 3.5-ish times the number of ER visits with alcohol use disorder, and about double the number of deaths. Certainly, this is not to say that OUD is not a severe problem, and it certainly is. I've done some work in this area, and we've found that people with opiate use disorder they have really severe needs. Oftentimes things like housing and food insecurity, transportation, other other um, uh, other legal issues. And that's not to say that people with AUD don't have these problems, but they're typically not as severe. But we're sort of finding ourselves in a conundrum here, So, um, the acuity score may not be as high with alcohol use disorder, but in total, right, across all people in the U.S., alcohol use disorder is actually a bigger kind of social issue. The other sort of major distinguishing feature between opiate use disorder and alcohol use disorder is this idea of treatment and social acceptability. So really, there is no safe level of opiate use, unless a physician prescribes a certain time-limited dose for pain. So a person who develops an opiate use disorder, really their only option is to achieve abstinence. We can do that in a number of ways, with lots of good treatment programs, including opioid substitution therapies, things like that. But alcohol sobriety or abstinence isn't always the best choice, and it isn't always attainable. Of course, alcohol is also legal. Illegal opiate use is not. Alcohol is widely available, and most people store it and keep it in their home. Add to that this idea that infrequent small quantities of alcohol use pose no threat, and increasingly you see people, treatment agencies moving towards kind of this harm reduction model where people are still drinking a little bit, and that's considered successful treatment. So let me give you some numbers kind of in New York here. Now, a minute ago I said that, let's see if I can, I guess I'll fit up there. A minute ago I said that alcohol, assessing alcohol problems can't really be done by quantity and frequency. And that's generally true with one exception, and that's for this age group here. There is a group of people for whom alcohol use is illegal, and that's people under the age of 21. So when I see young people, especially very young people, 12, 13, 14, 15, drinking, that is a concern, and we do have a policy issue there. Again, any alcohol consumption, by people over the age of 21, not really a concern, and certainly not really a concern for people age 26 and older. There is a quantity level, though, at which alcohol becomes, at which it starts to pose a risk and it becomes a concern. And that's what's known as a binge. So a binge is 4 or more drinks in a sitting for men, or 5 or more drinks in a sitting or a day for men. And you'll see me refer back to this 4 or 5 level here at a certain problem. So kind of everything in this column is a concern, whereas everything in this column is not necessarily a concern. This number is a concern, but these two numbers aren't necessarily. On the other hand, everything in this column is kind of a concern, and something to be sort of especially concerned with is this 66,000 here. That means that 66,000 New Yorkers between the ages of 12 and 17 reported binge drinking at least once in the previous month, and this is according to the National Survey on Drug Use and Health. These numbers are certainly a concern as well. That's so. All of this, though, is to say that when we screen for alcohol problems, we can't simply ask about quantity and frequency. We have to use one of the validated screenings. The ones that I like are the CAGE and the TWEAK, and these are acronyms. And you can remember the questions pretty easily, so they can sort of be very efficiently deployed in any kind of an assessment that we do. So the CAGE stands for Cutback, Annoyed, Guilt, and Eye Opener, and so the questions would look something like this. Have you ever felt as though you should cut back on your drinking? Has anyone ever been annoyed with you for drinking too much? Have you ever felt guilty for drinking? Or have you ever felt guilty after a night of drinking? And have you ever had an eye opener or a drink first thing in the morning to get going? Tweak is very similar, but it adds a tolerance question. Have you noticed that your tolerance has changed recently? Either it's gone up or decreased dramatically. Has anyone ever been worried about your drinking? Do you sometimes have an eye opener or a drink first thing in the morning to get going? Have you ever forgotten what's happened after a night of drinking, or had someone told you about something you did that you couldn't remember? And have you ever felt a need to cut down? And you have to replace the K with the C there, but that's what it is. Like I said, I like these because they're pretty easy to remember. If a client endorses one or more, that simply means additional screening is appropriate. Doesn't mean that they have an alcohol use disorder. It simply means that additional screening is appropriate. And there are lots of other screens all available online: the Audit, the MASS, the CRAFT. The DAST is a drug screening one, but I put these up there so that you have an awareness of the different screens that are out there. Excuse me, that caught me out of nowhere. Different screens that are out there for alcohol and drugs. There are, if we're going to make a diagnosis of alcohol use disorder, you need 2 of 11 items in the past year. 2 of the 11 items in the DSM-5. The items can kind of be divided into these 3 buckets or 3 categories, and so it doesn't matter what category that they what category of bucket that they fall into. But if a person endorses 2 or more in the past year, then that meets the criteria for alcohol use disorder. Now, one of the shifts from DSM-4 to DSM-5, which is 7 or 8 years ago at this point, but we moved towards a categorical and a severity rating. So the categorical is the yes, no, 2 or more. And then the severity rating is the total number of these 11 criteria that have been endorsed. And the severity ratings are mild, moderate, and severe. Person who has mild AUD endorses 2 or 3 of these items. Moderate is 3, 4, or 5, and then mild is 2 or 3, moderate is 4 or 5, severe is 6 or more. I misspoke there, excuse me. So 2 for the diagnosis, and then 2 or 3, 4 or 5, 6 or more for the mild, moderate, and severe thing. If you only need kind of 11, 2 of the 11 items for someone to give someone a diagnosis, you can imagine there's actually quite a bit of between person heterogeneity. So, person 1 might endorse these 2. Person 2 might endorse maybe this one and this one. They both have alcohol use disorder, but they both have very different kinds of alcohol use disorder. So if you want to do some, sort of back of the envelope math here, between these 11 items, and if you only need 2 of them for a diagnosis, there's about 2,000 different combinations that could present that would qualify someone with an alcohol use disorder. What this means is that alcohol use disorder is incredibly heterogeneous. It doesn't look the same from person to person. We actually did a paper on this, I think last year, just looking at sort of which of the items were most frequently endorsed across a given population of people. I had another paper, though, that actually looked at the within-person heterogeneity. So I'll give you a summary here in a second, but this is quantity. This is actually number of days abstinent per week in sort of 3 different groups of people, and what we're looking here at really is the change here in these lines. So this group, increased their abstinence per number of days abstinent per week by about 1. This group increased their number of days abstinent per week by about 2.5, and this group increased their number of days abstinent by about half a day. And that's without any treatment, without any prompt altogether. And so what we now think about alcohol use disorder as is something that also has a significant within-person heterogeneity, in this idea of kind of a downward spiral, culminating in like homelessness and just, really extreme, really extreme patterns of drinking just isn't true. What is true is that a person with alcohol use disorder moves in and out of really heavy periods of drinking, and they could move in and out of these heavy periods rapidly or slowly. And some of those periods of heavy drinking might last for a couple of days, a couple of weeks, a couple of months, but they're not permanent. And there is sort of this ebb and flow. Suffice to say, we're now sort of at the point in our understanding of alcohol use disorder where we get that it's heterogeneous between people, so it's heterogeneous from person to person. It's also heterogeneous within people. So the same person at 2 different time points, it might look very different. This makes doing alcohol work actually very very complicated and very, very complex. We'll get to treatment here in a couple of minutes. The other sort of diagnostic framework is the ICD-10. That's what physicians use, and that's the DSM is used broadly in North America, parts of Europe, but the ICD-10 is used elsewhere. And it is a little bit different. You need 2 or more of impaired control, increasing priority, and then one of these physiological features. Let me spend a few minutes talking about kind of development course of alcohol use disorder. So this line sort of represents a person's life, or the life course. And way out here, what we have is initiation, or age of first use, age of first drink, that kind of thing. Most people try alcohol for the first time at between the ages of 12 and 15, sometimes a little younger, sometimes a little earlier. That first sip of a parent's beer or glass of wine or something like that isn't necessarily problematic. What's problematic is a first drink that's done sort of without parent or caregiver knowledge. After sort of this age of initiation, right, sort of first use that happens without caregiver knowledge, you typically see the age of first drink, or first, age of first drunk, and that's really the age that the age at which a person became intoxicated for the first time. That for most people happens between the ages of, say, 17 and 19. For people who go to college, that often coincides with, that first semester or first year in college. Certainly, so peak drinking for most people happens between the ages of 18 and 21, which does coincide with those college years. After that, there's a what's called a natural desistance, or sort of a maturing out, and that happens throughout the age, throughout one's 20s and throughout one's 30s, and that's fine. A lot of people, do drink heavily while they're in college, and there might be some consequences, particularly academic and social consequences, but once they graduate, there's a sort of a natural desistance, and alcohol never really is a problem for them for the rest of their lives. Certainly, people change their drinking behavior if they have consequences. They have fights with friends or loved ones, or parents. And then there are a number of protective factors that steer people towards reduced drinking. So a lot of the major developmental milestones are protective factors. So getting into a long-term relationship, becoming a parent, getting a first, sort of first full-time employment. These are all protective factors, and they're part of that natural maturing out or desistance process. But there are some people who continue to drink despite consequences, and the onset of addiction for most folks is in the early 30s. Now, the clinical course or clinical career of AUD is about 20 years. It's a very, very long time, and it's marked by kind of three distinct phases. The first is 4 to 5 years of self-change, where people are trying to control their drinking on their own. They might impose rules. I'm only drinking on the weekends. I'm only drinking, I'm not ever going to drink more than X number of drinks. I'm only going to drink, when I'm with friends, that kind of thing. And certainly some people are successful with self-change. There then is a period of about 8 years where people are seeking treatment, and the average number of treatment episodes before someone is successful is 5. So a person has to attempt treatment 5 times before finding success. And that this period is called help seeking, right? So that the advent of help seeking happens about 5 years after the onset of addiction. Once treatment has been successful, there's a period of about 5 years where a person requires ongoing care, and that's to get them to this point, which is a less than 10% risk of relapse. So, like I said, it's about 20 years. So there's a real chronicity to alcohol use disorder. So how many people need treatment in New York? Well, there are about 800,000 who need treatment for alcohol use disorder but who are not getting it, over 1 million who are not getting treatment for substance use disorder, and about 473,000 who need but are not getting treatment for illicit drug use. New York is actually one of the places that's different than other states, where in a lot of other states, the need for alcohol use disorder treatment is higher than the need for SUD and illicit drug use treatment. So let's spend a few minutes talking about treatment here. It's sort of a couple of different kind of categories of treatment. One is the self-help or mutual aid or natural recovery. It's things like Alcoholics Anonymous, Narcotics Anonymous, moderation management. And there is some research to suggest that about 43% of people recover without professional intervention. For those of us who are kind of in the alcohol treatment and alcohol research world, we probably need to be really thankful for sort of this parallel but informal system of treatment that is the AA world, because they're doing a real public good, and they're and no one's paying for it, right? They're an amateur organization. They're not a professional organization, so they're picking up some of the slack where sort of other treatment systems are not. Self-help, though, is not for everyone, and for women in particular, self-help is pretty unappealing. Self-help is, it's dominated by men. There's a real emphasis on sort of spirituality and a person's own shortcomings. So there's a big group of people for whom self-help just isn't a good option. And for that group of people, we have a number of kind of empirically supported treatments. In terms of goals for alcohol treatment, there's sort of 2 categories of goals: abstinence versus a reduction in alcohol use. There's sort of 2 different points of treatment. One is to initiate abstinence or a change in drinking, and a second is to maintain abstinence or a change in drinking. So I'll run through these here real quick. Let's talk about medications first. There are a couple of medications They're not particularly good, and they're not any better than the psychosocial treatments that social workers are doing. In fact, um, of of all the people who are getting alcohol treatment, about 4% are getting medication. So it's a very, 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 very small percentage of people who who actually get medication. And even among those who are taking medication, the combination of medication and psychosocial intervention is almost always what a prescriber will recommend. So disulfiram is the first of the medications, can be used while an individual is still drinking, and what it does is it actually makes a person feel ill as a result of drinking. So they what the idea is that they learn to pair drinking with the feeling of being ill or sick, and so it recalibrates our expectancies or our learning outcomes. Naltrexone can also be used while a person is still drinking. It does something very similar. It reduces the reinforcing effect of alcohol. Vivitrol is the brand name, and that is an oral or injection administered every month. And acamprosate is the third medication, but an individual needs to be abstinent once they've in order to take acamprosate. And if they can be abstinent, acamprosate helps a person maintain abstinence. So let's talk about some of the psychosocial treatments, especially some of those that are empirically supported. First is contingency management. Second is cognitive behavioral coping skills for alcohol use disorder. So contingency management basically pays people for behavior change. So they're compensated typically with a gift card that's redeemable for merchandise of some kind, when they have negative urines or negative tox screens. There also is a punishment for positive tox screens, and that's usually a penalty on the following voucher. A penalty on one of the other vouchers. So, as you can imagine, although this treatment is empirically supported, there's a lot of places that don't like it because, or a lot of states that don't like it because what you're essentially the challenge is that while we're paying a person to be abstinent, they should be abstinent anyway. We're not going to pay people for something that they should be doing. The challenge to that is that learning, alcohol use disorder is a learned behavior, right? It's something that's learned over the course of many, many trials of drinking. And so we need to support people while they're unlearning that behavior, or more accurately, learning a different behavior. Places that do this, do it well, and they have, sort of a really good, really kind of a good system set up. The treatment, though, that I see used more often is really a cognitive behavioral approach. You can get trained for free online. You can read the manual. It's online. It's a great sort of skill to have in your intervention intervention arsenal. And the idea with the cognitive behavioral approach is that you're working together to reinforce the acquisition and maintenance of the skills to say no to drinks or to drinking. And so it's really on kind of overcoming a deficit. So there's a big emphasis on skills that involve managing affect. So you're upset, what do you do? You're angry, what do you do? You're just had a fight with your boss or your spouse or your kids, what do you do? How do you tolerate those emotions without resorting to alcohol use? Those are called either adaptive coping or active behavioral coping strategies, something like that. But it's doing something healthful as opposed to turning to alcohol when you feel upset. Most CBT is 8 to 12 sessions in duration, 60 to 90 minutes. And social workers are a big part of the group of professionals who are doing this. Outcomes are really good for CBT. Outcomes are actually better than sort of an atheoretical approach, where people just sort of come in for open-ended, open-ended kinds of treatment. About a third stay abstinent. Everyone else shows a decrease in consumption, and those alcohol-related problems decrease by about 60%. So is it perfect? No. Is it good? Yeah, it's pretty good. But again, in the alcohol treatment world, perfection is not what we're going for. What we're going for is often something more in line with a harm reduction approach. So, we're going with a reduction as opposed to an elimination. It is the case that about 50% of people are going to relapse within a year. And that's where, if you go back a number of slides to sort of the life course of alcohol use disorder slide, people need 5 attempts at treatment in order to find something or get something that sticks, and that's reflected in this 50% kind of relapse rate. So this is some work I did that shows some of the changes in behavioral indicators. This was 12 sessions of CBT. Like I said, the outcomes are good. We see changes in the kinds of things that we want to see changes in. I wanted to get you to a study that we did on reduced drinking, and that's this year. We used the WHO drinking risk levels to evaluate the effectiveness of CBT, and this is essentially what the results looked like. So there were a number of people, more than 50% of the people, who were drinking at very high levels, and that that's 3 or more drinks per day for women, 4 or more drinks for men. So not quite a binge, but sort of just under a binge. So about more than half were drinking at a very high level at the beginning of treatment, and as you can see at the end of treatment, we had more than 90%, just about 90%, who were drinking at a low or moderate level. Now, the WHO recommends a 1 or 2 level reduction as the optimal outcome, right? So it's not a complete elimination of drinking; it's a reduction of 1 or 2 levels. We had, more than, 50, 64, just about 2/3 or so of people who decreased 1, 2, or 3 levels. Now, keep in mind, some people could only decrease 1 level because they were already drinking maybe at a moderate level. And there actually were some people who couldn't decrease at all because they were already drinking at a reduced level. But this is an example kind of what harm reduction research looks like. It's looking at the outcomes of existing treatments, but in a harm reduction framework. So a couple of just kind of key points here. I think the key policy issues to be aware of in alcohol use disorder are blue laws. So blue laws dictate when you can buy alcohol, and in New York, you can't buy alcohol before noon on Sundays, and that's simply designed to encourage a certain kind of behavior, encourage the absence of a certain kind of behavior. Obviously, impaired driving is illegal, as it should be. So that's a second policy issue. A number of other policy issues have to do with the prevention of initiation of drinking and first drunk. Those are educational programs in schools. Those are restricting sales. Those are requiring, ID, that kind of thing. And that's designed to delay the age of first drink and the age of first drunk. If we can delay all that, we're preventing AUD from happening, downstream or downriver. And then the last sort of the policy issues has to do with funding for AUD. So funding for most AUD treatment comes from the state or insurance companies, and that's going to determine what kinds of interventions we can do, who we can see, how long we can see them, and that kind of thing. So if you have questions, feel free to let me know, but hope this was a helpful kind of overview of the AUD world.